70 years old, well, after the age of 60, but 70, 80-year-olds, this is a common problem, presents as a serious one-sided headache. The scalp is tender. Anytime somebody says, an old man says the scalp is tender, you need to pay attention to that. In addition to that, they usually have a visual disturbance, fleeting blindness. If you don't fix temporal arteritis, which is really easy to fix with steroids and NSAIDs, it responds really well to steroids and NSAIDs, you can wind up throwing essentially a clot to the retinal artery and blindness. It's a vasculitis of medium-sized vessels. That's the pathophysiology of it right there. An arteritis, an inflammatory arteritis of medium-sized vessels. The thing about temporal arteritis, the diagnostic thing is when they go in there, you send them to a surgeon, a general surgeon, and they go and biopsy the superficial temporal artery, and they have these multinucleated giant cells. That's the pathognomonic feature of the biopsy. Most of the time, you're not going to biopsy these people. You're only going to biopsy if you're not sure what the diagnosis is. But you always want to get a SED rate or a CRP, C-reactive protein, because it will always be elevated. Okay? You get an 80-year-old man with an elevated ESR, headache and scalp tenderness, they better go home with 80 milligrams of steroids to take for a while. And it's more than just a few-day taper like we've described before. Okay? You want to put them up for a couple of weeks at least before you start tapering. Cluster headaches. This is an odd animal. Cluster headaches usually occur in men, and they are non-pulsatile. And it's like if you were to take a steak knife and put it on an open flame stove, and get it blinding red hot, and then take it and stick it right through your eye, right back into your skull, that's a cluster headache. It's retroorbital, one side, stabbing, searing, painful, to the point of suicide, and it happens every day at the same time, 2 weeks, and then it's gone. Every afternoon at 5 o'clock, it comes on. It'll last for 2 to 3 hours and go away. And I'm just using it as an example. The thing about cluster headaches is they occur in clusters, temporal clusters, and they're intermittent. I had it back when I was 18 years old. I didn't know what it was then, but I do know now. I had a cluster headache for 2 weeks. Every afternoon, about 5 o'clock, I'd get this headache, and it was just horribly painful. And I could eat Tylenol, ibuprofen, did nothing for it. But it was just like something was taking, just stabbing me right in the eye. Lasted 2 weeks, I've never had another. The weirdest thing. So, but these things this is relatively common. You're going to run into this. The treatment for cluster headaches, believe it or not, is, it says it could be precipitated triggered by alcohol or vasodilating drug. I didn't drink alcohol then, so I don't know what the trigger was, but it did happen. Patients may then go without another cluster for months or even years. So I've gone now 30-something years and never had another one. Okay.
Is it only 2 weeks, or is that just like an
No, it can
average?
be 2 days. It can be a month. It's very variable.
Okay.
The thing about cluster headaches, though, is they occur at the same time of the day. It might be 1 o'clock, it may be 9 a.m., it may be 5, but it's around the same time of the day where you get them. It's not 9 o'clock one day and 5 o'clock the next day. It's mostly around the same time. History is what gives you the diagnosis. There's no imaging studies you can do. You're going to have a normal SED rate. It's just nothing you can do. The treatment here is oxygen, believe it or not. somebody comes into the clinic, or if you've diagnosed somebody with this, get them home oxygen for a few weeks until it goes away. But you put high flow oxygen on them by a mask, 10 to 15 liters a minute. It says 8 to 10. Open it up, flood them with oxygen, and that seems to make, and I don't know if it's because the high oxygenation will decrease the diameter of the blood vessel. This is a vascular headache, but it's not pulsatile like a migraine. Okay?
I have a question. What indicates you to not get a scan? Like if someone presented with some of these symptoms, I would be more concerned.
What was the first part of the question?
Like what would prompt you to not get a scan or imaging study?
The history, if somebody came in and described a classic cluster headache, I wouldn't image that.
Okay, because like Professor Bean, when she had hers, she went straight to the ER and she only had it for like 3 hours.
Yeah, but she's a little, you gotta think about something else going on with her, They probably did a whole body scan. The other thing about scanning is the way medicine is now, if you go to the emergency room, you're gonna get scanned. But you don't need to get scanned. But people just avoid the possibility of malpractice by scanning everybody. So, if somebody came in with a classic cluster headache, I'd be spending my time trying to get them an oxygen bottle and a mask at home rather than sending them over for a CT. Tension headaches are, these are the kind that you get. These occur in all sorts of people. Says 60% of primary headache. That's probably not true. So the tension thing, it says women are more commonly affected than men. That's true. So I look at it, you see where it says classic description of neck and scalp muscle contraction may well be secondary. I think it is secondary, but that's the damn cause of it. That's the pathophysiology of it right there. So what happens is you spend 6 hours today hunched over that computer. You spend 12 hours on Saturday hunched over reading your notes. So your neck muscles are just getting tired and they start spasming. You can feel it, right? You can feel the spasm. And that spasm is in your occipitalis muscle as well. You know it, right? You feel it, right? You feel it. And that occipitalis is connected to your frontalis by the aponeurosis, and you feel it like this, and because it's in the front and the back, it feels like there's a constricting band around your head, and you definitely have it right here. That's a tension headache. History will usually get you the answer. It's not pulsatile because it's more muscular mediated. Band-like pattern is the pathognomonic feature for a tension headache. They don't come with aura or prodromes. There are no neurologic signs. It's just a headache. Now you treat these things, so diagnostic studies. You can do SED rate essentially to rule out temporal arteritis, but temporal arteritis in somebody your age just doesn't happen. Okay, CT to rule out to be on the defensive side of medicine, but you can diagnose a tension headache just by the history. A student comes into the clinic over there, it's a tension headache. Okay? The way to treat tension headaches is NSAIDs. You don't need to, triptans don't work. You don't need to get really aggressive with them. You just give them a good healthy whopping NSAID, and that takes care of the problem. The other thing that takes care of the problem is, you know, of course you can do peripheral thing, but a muscle relaxant. Give them a Flexeril, 10 milligram Flexeril pill to take before they go to bed, and it'll take care of that headache. Okay? The study-wise headache. You know, when I was in graduate school, I ever tell you a story about Tony the Bonehead?
Yeah.
Tony the Bonehead. He had a tension headache, he went to the ER, he shot his ass up with Valium. He slept all the way through the biochemistry exam. So, muscle relaxant, you know, PO muscle relaxant, much more gentle than IV Valium. But that's all it was, a tension headache. Glasgow Coma Scale, you guys have heard of this? Glasgow Coma Scale? Okay, you haven't heard of it? All right, so this is, when somebody comes in the emergency room due to trauma or altered level of consciousness, you need to determine their placement on the Glasgow Coma Scale. The Glasgow Coma Scale, the maximum you can get is 15, the least you can get is 3. And it looks at 3 different things. One is your response, your eyes, whether they're open, whether they respond to commands. The other is muscle function. Over on the right side, the motor response, whether or not you have flaccid muscles, or if you're posturing where it says extension to pain versus flexion to pain. And then the other one has to do with your response to, hey, you know, wake up, or open your eyes, that sort of thing. So you give them a number here. You are going to score a 15 right now. Anybody that scores less than an 8 gets a CT. That's an automatic justification for doing a CT. It's not defensive medicine. You should CT them if they score an 8, or I said less than an 8, it's 8 or less. Concussion, we talked a little bit about concussions yesterday. Here's a little bit more about them. Again, not related to specific neural trauma. The hallmarks here are confusion and the retrograde and anterograde amnesia for a brief period before and after the event. Okay. LOC, you always want, anybody gets knocked on the head or a concussion, you always want to determine whether or not there's loss of consciousness. Your note needs to have an LOC. Patient, if they're in a car wreck, you ask them 2 things. One is, were you knocked unconscious? 2, do you have seatbelts on with airbags? And you note those 3, right? Restrained, no loss of consciousness. That tells you a lot about an accident victim right there. If you're knocked unconscious for more than 2 minutes, that's an automatic admission to the hospital. 2 minutes, knocked unconscious. You get some football player at the high school, he gets his bell rung, he's knocked unconscious for 2 minutes. He doesn't go back in the game, he goes to the ER. And he should get admitted overnight, at least, for observation. The things that can happen with concussion, at least initially, of course the headache, the unsteady gait, the wobbliness, you know, you see the people being helped off the field, football players, there you go. Okay. Later on, if it's a serious concussion, these types of things can manifest more psychological rather than somatic. And for longer periods of times, or if concussions are repeated, you start getting these things that just don't go away. Again, going back to punch drunk, if you YouTube the video of somebody punch drunk, you will see that a lot of these things are manifest pretty easily. Okay. A diagnosis here, you want to get a CT if you think that there's a significant concussion because you want to rule out a bleed or a skull fracture, not or, and. So when does the CT need to be done following a concussion? There's a whole list of things here. In a high school athlete, if they score less than 15 on a Glasgow Coma scale, they don't have to be 8. If it's less than 15, you get a CT. Okay? Then others are pretty obvious and intuitive. If you're in a high school football game and some kid gets whacked on the head and knocked out and he's having a seizure, you shouldn't have to debate on a test question whether or not that needs to be scanned. Yes, scanning, okay? If they're on anticoagulants, as most people are, over the age of probably 60, scan them, ruling out bleed. So treatment for a concussion, neurochecks, which is what I talked about yesterday, that's kind of the, if you're gonna send them home, that's what you wanna do. Have somebody, make sure they don't live alone. If they live alone, then you need to keep them in the hospital for observation. If they have no one to come and stay with them, keep them in the hospital for observation. If you're gonna send them home with somebody, make sure you instruct that person on neurochecks. Can you arouse them during the night? And of course, if the headache worsens, if they start vomiting, visual changes, anything like that, they need to come back, and then you need to scan them. If they bounce back, here's a rule. If somebody with a concussion bounces back, in other words, they come back to the ER, scan them. Post-concussion syndrome is, well, when you're talking about traumatic brain injury. So this is, you kept sending that little football player or that pro football player back into the game, and now look at him now, years later, what's happened to him. All sorts of things can, bad things can come in post-concussion syndrome. This used to be not recognized, or it was actively ignored, and of course now it's not. And taken seriously. And even, starting quarterback from New England, he got a concussion. They went through the concussion protocol. They kept him out of a game. A guy making, $15 million a game is kept out of a game because of the seriousness of this. Tom Brady, if you don't know who that is. A little bit of information here, CT, 10% show an abnormal bleed in a post-concussion syndrome, but most of the time it's not going to show any pathology unless it's an autopsy. Autopsy will typically show pathology associated with this, but not prior to death. The treatment for it is dealing with the headache, the pain syndrome, and the psychological manifestations of the disorder itself. The prolonged disability is the thing you want to avoid, and the big thing that's active in the NFL right now. Okay. All right. So see, we didn't even make it till 3 o'clock. Kendall? Any questions? See you tomorrow.